We'll take a look at now systemic disease with nephrotic syndrome. This is diabetic glomerulopathy. So, first, we'll take a look at nodular glomerulosclerosis. Some of the damage that you find with diabetic glomerulopathy is the fact that you will then have these depositions in the mesangium. That is not the first change, but it is a change that's important for you to know on light microscopy. And this, of course, is referred to as Kimmelstiel-Wilson disease or nodules. The glomerulopathy occurs in both type 1 or type 2, but occurs more often in type 1 than in type 2. More common cause of chronic renal failure in the U.S. as a whole, when you go into diabetic nephropathy, it is the most common cause of renal failure, isn't it? Now, obviously, in terms of which one going faster, well, perhaps, it depends. Type 1, and maybe because of fluctuation in insulin level and non-compliance and so on and so forth. So, a number of factors here. Nodular glomerulosclerosis, well, what might then happen? That then represents poor glycemic control, hence the severe diabetic damage. Hypertension, diabetic retinopathy, and correlating with coexisting glomerulopathy. Now, a couple of things that are important here. You've heard of metabolic syndrome X, which is hypertension, hyperglycemia, hyperlipidemia. Two of the three are here. Hypertension, hyperglycemia. Poor glycemic control. Hypertension. If you have diabetic nephropathy, wow, what other organ are you seriously worried about right now? Retinal detachment, blindness forever. Diabetic retinopathy, and usually correlates with coexisting glomerulopathies. Maybe membranous is taking place as well. Non-enzymatic glycosylation is the pathogenesis. What does that mean? A glucose is doing what? A glucose is binding to protein, non-enzymatically, causing damage up and down the body with diabetes mellitus, as we shall see in endocrinology. It could be diabetic retinopathy. It could be diabetic neuropathy. It could be diabetic cardiomyopathy. It could be diabetic nephropathy. It could be diabetic microangiopathy. All of this, non-enzymatic glycosylation, attaches to protein without an enzyme. It increases vessel tubular cell permeability to protein, so it may result more so like how? Nephrotic or nephritic? Good. Nephrotic. Now, important here. Non-enzymatic glycosylation, NEG, NEG, of the afferent and efferent arterioles. Picture this. Here's my glomerulus. Here's my afferent. Here's my efferent. I will have hyaline arteriolosclerosis. Please highlight in your head forevermore. Hyaline arteriolosclerosis. Afferent, efferent, or arterioles. They're undergoing narrowing. Important. Interesting. Why? Pathologically, we know this is true. Involves efferent arteriole before the afferent. Wow. Why is that important? Good. You should be thinking, what's one of the first dipsticks that may detect your patient having diabetic nephropathy? We talked about this urine analysis. Give me one of the first dipsticks that you'd be using in the urine to then suspect diabetic nephropathy. Microalbuminuria. Okay. As soon as you find microalbuminuria, what are you going to give to protect that kidney? ACE inhibitor. What does an ACE inhibitor do? Removes effective angiotensin II. On whom? Good. Efferent arteriole. Why is that important? Are you seeing this? Take a look at that last statement. Efferent arteriole undergo sclerosis. What's it going to do? Spank the glomerulus, isn't it? At some point, you're going to cause damage. So, why not relieve some of that pressure by giving ACE inhibitor? Understand that, please. Clinically, huge ramifications. Osmotic damage to glomerulocapillary endothelial cell. What does that mean? There are two major pathogeneses. The first one we talked about, non-enzymatic glycosylation. The osmotic damage, well, the best one to give you as far as the pathogenesis would be, well, sure, diabetic retinopathy is an issue. The retina is not the same thing as your lens, is it? Right? There's my lens. and said that my lens was white. It looked white, like the waterfall. You ever seen those pretty waterfalls? Let it be Niagara, Brazil, Angel Falls, whatever. But you ever seen the waterfall? What does it look like on the outside? It looks white. What is that in Greek? Cataract, right? So cataract means waterfall. A beautiful name for two reasons. Number one, the lens, which normally should be clear or clearish, now looks white, a cataract. And number two, that glucose, read the statement here, instead of going through a glycolytic pathway, ends up going through aldose reductase pathway, and you end up creating sorbitol. How many times have you seen the back of a sugar packet or artificial sweetener, and it says sorbitol? You might want to think twice, because in diabetes, there might actually be accumulation of sorbitol, maybe here in the lens. Uh-oh, here comes my waterfall, osmosis of fluid into the lens, causing what? Cataract. So two major pathogeneses here. Number one, non-enzymatic glycosylation. The other big one here is through your aldose reductase pathway, forming the all-toxic, in abundance, sorbitol. Osmotically active, what does it do? It increases osmotic pressure. Here comes my water into, as I've given you as an example, the lens, resulting in cataracts. Hyperfiltration damage to the mesangium is important. There's selective hyaline arteriolosclerosis of the efferent arteriole that we talked about. Listen to that statement. That's important. The efferent arteriole undergoes sclerosis. What then happens to the glomerulus? I couldn't be any more dramatic. I just said spank, 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 spank. So now there's hyperfiltration. There's hyperfiltration. Imagine, how long does it take for you to go into diabetic nephropathy? Decades. So my goodness, at some point, the glomerulus can't take it anymore. There's increased GFR, which damages the mesangium. Are you putting all this together with kidney damage, but obviously with diabetes mellitus, it's a systemic issue from head to toe. What else might you find? All I'm doing here is giving you one particular issue within the kidney, such as Kimmelstiel-Wilson disease, but along with this, you know that there's other issues probably already taking place in your patient. Diabetic microangiopathy. What does this mean? Increased deposition of your, non-enzymatic glycosylation of type 4 collagen. And you might have glomerular basement membrane, tubular, and basement membrane and mesangium all being involved at the same time, causing all kinds of issues. Non-specific immunofluorescence, as far as the labs are concerned. Electron microscopy shows fusion of podocytes. Really, it seems like it would be a nephrotic type of issue, but what are you really paying attention to? It's a light microscopy, huh? Microscopic findings. Afferent, efferent, what kind of arteriolosclerosis? Hyaline. Versus hyperplastic. Hyperplastic won't be seen here at all. This is hyaline arteriolosclerosis. Hyperplastic will be seen with malignant hypertension, huh? Malignant hypertension, not here. When the afferent arteriole becomes hyalinized, now you have GFR decreased, the afferent. But that takes on a little bit later. Usually it's efferent first. The nodule masses develop in the mesangial matrix. What kind of mass? Talked about the Kimmelstiel-Wilson nodule. And due to type 4 collagen, non-enzymatic glycosylation is involved, and it traps the proteins, and that may be in the mesangium, glomerular basement membrane, or even in the tubules. There's something called Amalfi type of issues there. Let's continue. Laboratory findings. Microalbuminuria. What does that mean to you? First sign of diabetic glomerulopathy. Usually begins 10 years of poor glycemic control. 10 years is how much it's taken. And this is usually due to, lack of proper nutrition or not paying enough attention to your nutrition. The microalbuminuria dipstick detects albumin levels at quite low. You have to. It has to. Other renal diseases associated with diabetes mellitus, renal papillonecrosis, acute and chronic pyelonephritis. What does that mean? That's a lot of glucose in your urine over a long period of time. So what does that mean? Wow, patient, your urine is mighty tasty. What's going on? There's a lot of glucose in that urine. It is sweet urine. Who is it feeding? The E. coli? So you got bacteria. Oh, not good. So you might then have, here comes E. coli coming up the urethra. It comes up further. It may then go into the kidney. What is that called when you enter the kidney? A deep portion might result in renal papillonecrosis, acute and chronic pyelonephritis. Woo, a lot of problems. And that renal papillonecrosis, well, some of this may end up in remember that junction? The pelvico-calceal junction may result in obstruction type of issue. Good stuff. But if your pathophysiology was weak here, then you might have, I'm thinking at this point, you're developing a nice little story here in which you're seeing all the complications. And I'm just trying to give you as many angles as possible.